Good morning and welcome to our webinar today, which is about optimizing home injections. We're going to talk about both adults and kids, and we're going to talk about injections like diabetes, but also primarily biologics and how to set these up for success. There is a lot of new information in the past 2 years, and I am studying new neuroscience on the nature and interactions between fear, pain, experience, and compliance. So all of those things will be discussed. Little bit of housekeeping. If you have a question, please put it in the Q&A and I will try to address it as we go. There will be time for questions and answers at the end of the session, and this webinar will be available in about a week to those who have signed up for the information. So to get started, the disclosures. Normally when I'm speaking, I'm doing it at a national lecture, and so I have to include the fact that I have a company that makes devices that block pain. But I will disclose these things today, even though I think you already know it. And I will talk about the objectives for today. So we're going to try to optimize home injections for your patients, yourself, your family, or to orient you if you're making biologics to the optimal way to get your patients set up for success. My goal at the end of this is that you will actually know more than anybody about the current state of affairs in home injections. If I have a needle that I show, I will try to have a trigger warning box covering it. So if you are someone who has vasovagal issues, you'll have a chance to look away and just listen while I'm talking. We're going to start with some of the history of needle fear, which impacts adherence, and then the neuroscience of how pain, fear, and control are all interwoven for a successful home experience. There's some really great new articles that talk about the rituals and the routines that help people be compliant. So we're going to talk about that and then give some examples of ways that your pharmaceutical company, or you, if you are one, can be involved in using pain management as part of the starter kit or making it available to patients who need the support. So our vision as we started this company was to eliminate unnecessary pain. And the idea was, if you could get rid of pain, why wouldn't you? So for anybody who had to have an injection, why not give them something that would rapidly block pain? This was the idea behind Buzzy. Now, Buzzy is a reusable device that vibrates in a frequency that cancels pain. This is like rubbing your elbow after you bump it. And it has research on everything from propofol pain to about dozens of discussions of and studies on vaccines, and about 4 times as many on IV access and infusions. This is what a successful Buzzy interaction looks like. This is, well, I'll let her tell you.
What are we doing today? Ready? Okay, Buzzy up. Hold them right there.
So Buzzy goes up between the brain and the pain after already numbing the area.
Press that into my ear.
Yep.
No,
The cover makes you stop.
and then put the one.
Yep.
Let me see. But it's tiny as a baby. Boy,
Okay, you ready?
don't squeeze it too hard.
Am I squeezing it too hard?
Yeah.
Okay, just a little bit. Ready? Good. Push it. Push it down.
Fine.
All the way down. Okay, look out. Good job. You did it yourself. Are you proud of yourself? Good job. Okay,
So drippy.
sorry, put the Band-Aid on. You're 5. Good.
Okay, this is an amazing video for a whole lot of reasons. In addition to the fact that she is 3 years old and giving herself her Enbrel, but there are a couple aspects we're going to talk about and revisit with this. One thing is she wanted to know why. And even though her mom answered a different question, it's really important starting off on a journey with medications that patients know why. She also was in control. And so for reducing her fear, she had the Buzzy, but she also was able to control the injection of the syringe itself. Another part of this that is a critical bit is that as her brother tried to throw her off her groove, that was when she lost composure just a tiny bit and said, "Be quiet." Rituals and routine and keeping the same mindset are extremely important in doing routine injections successfully. So this is just an astonishing and amazing example of how when the process is begun well, you can have success over time. So a little bit more a word from our sponsor. Buzzy has been shown to improve satisfaction with injections for adults. We're on the national guidelines for bicillin injections in New Zealand. Another bicillin injection study in Uganda used Buzzy. It was published in the New England Journal of Medicine, and the doctor who did it said, "Oh, we didn't even mention Buzzy. We consider it standard of care." But the mentioning in the protocol of Buzzy and how they did the study, that is online and published in the New England Journal of Medicine appendix. So Buzzy has at this point decreased pain from over 54 million injections. It is overwhelmingly the most studied for pain, and it's used for everything from diabetes, finger sticks to IVF. Most of the time, patients are going to hear about Buzzy from their doctor. So pain control by itself is not enough. We found early on in using Buzzy with kids that, as you can see in this little guy's face up there, that even if the pain was reduced, there still was a fear, reluctance that could overwhelm. We understand now that all of the warning signal of pain that goes to your brain is only part of it. So Buzzy stops the physiology of the signal or decreases it going to the brain, but the experience of pain is also the memory and the spotlight of attention. How much are you amplifying what you recall and selectively feeling for pain? So in order to optimize the experience of home injections, you need to deal with the physiology of the transmission of the pain, but also the fear and what the patient's focusing on. In the bottom picture, you can see that there's someone, now this is an IV access, but the concept's the same. So there's something to deal with the pain, and then there's a distracting set that she's looking at. So she has something to focus on and keep her composure while she's getting the procedure. To put it an easy way for patients to understand, fear and control are the volume knobs for pain. So we want to decrease fear, increase control. Now, why is needle fear an issue? Well, this was how I got into this whole area. And what we found in our research was that there was a huge increase in needle fear in people who were born after 1983. And if you look and see what the vaccine schedule was, you can get an understanding of why you might have a difference in needle fear. It turns out that before 1983, people only got 6 injections, and they got them before they were 2 years old, which is too young to remember. Now, children get up to 36 injections, and with COVID, it's even more. This matters because we've started giving injections at boosters at age 4 to 5. And so when we looked at kids who got different numbers of shots in their 4 to 6 year visit, we found that if kids got 4 or 5 injections on the same day during that 4 to 6 year age range, over half of them were severely afraid of needles when they were still early teens. So we really have anybody who's born before 1983 really can't talk about whether or not they're afraid of needles or not, because they didn't have this literally traumatizing experience of being held down and shot over and over again when they were old enough to remember. So this is why we have a serious increase in needle fear, up to 63% of those who were born in 2000 and later. Here's a way that you can look at the numbers of injections that are required at different times. Now that we've added COVID, it's going to be more like 38 to 40 separate injections until we get them combined. So all of this together means that when you have a home injection that is prescribed, you have a huge base of potential anxiety, fear, and negative associations. We actually looked at the amount of needle fear in the population compared to what the vaccine schedule was, and found that it has been going up extremely well correlated with what the vaccine schedule is. So we're going to be dealing more and more with people who are afraid of needles, and we need to know how to undo this. Now, one little pediatrician plug about vaccines, not suggesting changing the CDC vaccine schedule at all. The thing is, the boosters are given between age 4 and 6 anytime in that 3-year period. So there's no reason not to stagger them so kids are only getting 2 at the same time, rather than getting the 4 that severely correlated with the later needle fear. All right, so how does this manifest when you've got somebody who gets put on an injection at home? So this little guy had ulcerative colitis and was put on Humira. And his mom has a really great article in this improvecarenow.org, but she talks about how the diagnosis was made, the prescription was written, and she said everybody at the office was just acting like this was going to be no big deal. She said in reality, the process of negotiating would take nearly an hour, and when the shot was finally given, everybody was totally drained. She also comments on something that many people getting home injections say, which is that dread lasts for a day or 2 before the actual shot. So when people start knowing they're going to have to get it, there's a dread that comes along with the anxiety and panic before actually getting it. They actually did a study looking at who wanted a Buzzy of their patients, and unsurprisingly at the time, Humira did not have, Humira had citrate in it, so did not have citrate, so it was much more painful, and 80% of those getting Humira wanted it, 50% of those who had Remicade, which is a less painful injection, wanted a kit, and teenage males who were too cool were less likely to want it, but everybody appreciated it. One really fun thing is Buzzies tend to last, and so we got a picture last year of one of our very first Buzzy users when he was 5, starting on his Humira, and he is now 17 and still using exactly the same Buzzy. A lot of times people will say, particularly doctors, will say, you know, the thing is, my patients are adults, so it doesn't matter. Well, during COVID, I testified before the Department of Health and Human Services and talked about the fact that adult needle fear is actually very complicated and very prevalent, and that it was going to cause up to 28% of people not to get vaccinated because that's the incidence of adult needle fear in this country. We asked 600 patients who had not, or people who had not yet been vaccinated in April of 2020 about their intentions to get vaccinated and how they felt. So what was really interesting is these people had not yet been vaccinated for COVID. And so we asked them why they hadn't gotten a vaccine, and 16% of them said they were afraid of needles. Then we said, what worries you about getting a vaccine? And 23% said they were afraid of looking foolish or fainting. So now we're from 16% to 23%. But when we asked the question as a Likert scale, a sliding scale, and said, how afraid of needles are you? 52% said they were 3 out of 5, 4 out of 5, or 5 out of 5 afraid of needles. So that's almost half of, it's more than half of the people who hadn't gotten vaccinated had a severe fear of needles. and moderate to severe. And what was interesting was the people who were vaccine skeptics, they were 5 out of 5, I don't trust it. They were 3 times more likely to also be 5 out of 5 afraid of needles. Coincidence? I think not. So when you want to get people vaccinated, or if you're going to start them on injections, you need to entertain and address and destigmatize the concept that your adult patients may have needle fear. So the reality of needle fear is that it is classically conditioned. It develops between age 4 to 5 with a bad experience, which is why it's so correlated with the vaccine schedule once we started giving boosters. And 52% of adults have a 3, 4, or 5 out of 5 fear. Even with adults who have diabetes and are getting insulin, 94% of insulin users have fear symptoms with each injection. So that's on the daily or several times a day. If you can imagine someone who has to wait 2 weeks between each injection, it ramps up that time to have anxiety and fear. Of patients who are newly diagnosed with type 1 diabetes, one study found that 75% of them who were under the age of 9 had high fear of injections. Now, that number is going to be the same whether it's growth hormone or diabetes or asthma or any of the things that's going to require them to get injections. So it's really important to start off right before the home injections begin. It's much harder once things are already out of the gate. As I mentioned, it's a lot more complicated with adults because adults don't just have the fear and the focus that they need addressed. They've also got shame. They're more likely to have vasovagal fainting. They have dread. They have other lives, and they don't want to be foolish and mess up. At least children know somebody else is the one dealing with the shot or giving it, but adults have the additional pressure of wanting to make sure they do right. This is a really excellent study that was done in 2017. And what Schiff et al. Did was have 2 different ways to do open-ended questions, asking with different methodologies about how the process was for patients with arthritis who were getting injections or getting biologics, to ask them how they felt about the process and what was good and what was bad, and what was then correlated with them staying on their biologics. So let me take you through this because this is really rich and I highly recommend reading this article. So from the very beginning, the places that were problems and correlated with not staying on injections began at the primary doctor's office. Now it says GP here in orange. This was a study that was primarily done in the UK. But early in the patient's journey, people don't know what to ask about why they're on a biologic or what the options are. After this, because oftentimes it takes a little while for the doctor to categorize the disease or to find out what's going to work best, there's anxiety that's put in about taking a medication that may not work well. There also are issues with the education about the medicine itself. When's it going to work? How will I know if it's working? And one of the big things that this article talked about was that many diseases where biologics are involved, insurance or National Health Service requires that patients start with a first-line medication that may not be as effective. So methotrexate as an injection, for example, instead of Enbrel or Humira. And that is often not clear to patients. So they feel like they're taking a medication. They may have side effects like nausea. They don't understand what to expect and they don't know if it's working. And then they find that they have to change the medicine. So one recommendation of this paper was make sure that patients know early on what's going to happen and what the progress is and what is known and what isn't, so that they feel like somebody's in control and somebody knows that this is how it's supposed to be. It doesn't have to be a definite answer. It just has to be something that someone knows that this is the right process and this is how it's supposed to be. And then the education for how to get medications and how to do injection is also a source of anxiety, and where people were not as comfortable and they didn't feel like there was a way to talk back and forth with their doctor about this. All right, so if we're trying to design a program that's optimal for injections at home, how do we use this information? Well, step one, make sure the patient knows why. So before Tenley even got her shot, her dad said, "What are we doing?" And she said, "Taking my Enbrel." Now, she may not have known, been able to understand what kind of medical condition she had that she was taking it for, but she understood she was taking a medication and she knew why she was doing it. For someone who's a little older, understanding what the medication does and why it's this medication is really important. Probably not for a 3-year-old. Step two is to understand the medication timing. So how long is this person going to be on this medication, especially for a child who's starting growth hormone or Dupixent or insulin? How long is this going to happen? So this is not something to go over every single injection, but it's something when someone is starting on the path that they need to know to decrease their anxiety and improve the likelihood of staying on the medication. So for example, with type 1 diabetes, you'd want to say, well, we're going to do this for a little bit so we can get the right amount, but later on, there are ways that you'll be able to have something that will give you the medicine without having to take a shot every day. You don't need to get into pumps, you don't need to get into glucose monitors, but just at an age-appropriate level, understanding, is this going to be forever or is it not going to be forever? Forever is a long time. So one thing that can be helpful is when patients are starting as a parent or as a caregiver to say, you know, the thing is, what's going to happen? You'll know this is working because your skin is clear, your itch is gone, we don't have to go to the hospital for your asthma, your joints don't hurt in the morning. But if this medicine doesn't do those things, then we'll do a different medicine or do something else. So rather than saying this is a lifelong medicine, saying, you know, if this does these things, you will want to stay on it because it's doing so well for you. It makes you feel so much better. It makes you look better, be healthier. But if it doesn't do that, then you don't have to stay on this. So that gives, I mean, assuming it's not something like chemotherapy where you got to stay on it until you're done, but giving someone the context of, yeah, I mean, people do keep taking this, but it's because it works so well that they want to. So that framing of efficacy and why, what is the solution? So understanding the timing, if it's something where there's going to be a temporary trial, and then if it doesn't work, you upgrade to another medicine or change to another medicine, that kind of information is critical to a patient who's starting a medicine, adult or child. How likely is it to work? You know, about 3 out of 4 people are going to look much better in 3 weeks. That sort of thing is helpful. You don't want to use percentages because it's, when you're anxious, it's hard to digest a percentage, but making it very concrete. When will you know it's working? When do you expect it? What's the next step if it doesn't work? And then, and I think this is really important, and I think everybody should have it in their home kit. What does success look like? So for someone who's doing IVF, here's a baby who was born to a woman who was going to stop doing the injections because they hurt. And then she got a Buzzy and now she has a baby. So putting what the end goal is, putting a picture, visualizing that. Now, here's a starter kit that Buzzy's in. And one of the nice things about this is it's extremely clean. It's reassuring. It's not cluttered and anxiety provoking. When we have undertaken designing starter kits, using the steps that I just discussed, I would do something like helping my eczema. Say this is dupilumab. So having written on it what it's for. The next thing is giving somebody kind of a goal path. So for each of the injections, if it's going to take about 4 doses before itching is better in most people, have little boxes to check off. How's my itch? If after 16 injections or after 8 injections, in 16 injections, most people's skin is clear, then when you've done 8, put a little goalpost, yay, halfway to clear, but making this something that is moving toward a purpose. And then if the goal is to be able to go out and play because you're not immunocompromised because of the infusion, or if the goal is to look good, have a little picture at the bottom, have something that reminds all of you what the purpose is and what the process is, so that it's not an isolated thing to dread, but it's a positive, proactive step in taking care of health. All right, now back to the findings from people. So now we're on the circle of choice, learning, and doing. This, I think, the most important stuff that was learned here is that when we are teaching patients how to take the medication, we're not taking into account what they want, their choices, and how their behaviors or schedule may work. And it's really critical to talk to patients about this before they start, not to act like it's going to be in isolation. Just like Liz Dapp, she said everybody expected this was just going to go smoothly, and it was an hour negotiation and days of dread. And so to appreciate and understand that those are possibilities both normalizes them and takes away some of the fear of, oh my gosh, we're not normal, but it also is an opportunity to introduce things that can help. The other part that was found was that the learning and doing steps were very idiosyncratic. It was not common to have the nurses or doctors teach the patient in the same way. And one person said, generally, only the nurses have time to be compassionate. Doctors, we self-select to go into medicine because we're not that worried about needles. We're also very prosaic about risk benefit, but we don't tend to take into account patients' pain or anxiety as much because, if we have to set a bone, we have to set a bone. If we have to do surgery, we do it. And so we're not used to taking how the patient feels into account. And we should be. Nurses are better. So if a drug or device has to be changed, this is also something that you can anticipate by knowing the process of the disease and making sure the patient knows it, but taking a little extra time, even if it's exactly the same injection process, retraining just so the person is clear and comfortable and confident. And then one other part of this was that is relevant to what I'm about to talk about is that patients do struggle to store and travel with equipment. So it's an excellent idea if you can get a travel bag, or if you don't have a starter kit that includes everything, make one that does. Now, another study by Coyne et al. Looked at what are the optimal mechanisms for teaching. And so what they found was, I'm adding the why because I think that that's really important from Schiff's work, but for teaching with biologics, they found that you will do adult learning techniques. So have verbal instructions about what's going to happen. So the first time, we're gonna get the medicine out of the freezer or refrigerator, and we're gonna check it and make sure it's the right one, and we're gonna have a nice place for you to sit, and we're going to pull up the right amount of medicine and make sure it's warm room temperature, and then we're going to play your favorite music and do this. Then you show them. And so from a demo standpoint, you're not going to have all that at the office, but show and add in little language of, no, this is where you might do this. This is where you might do this. This happens. And then let the patient do it themselves. So as they said, providing patients device training, teaching routines and rituals concurrently, and providing home opportunities for practice reduces anxiety. What this says to me is that videos are critical. Having videos that someone can watch. And if you don't have a normal set of routines at the clinic office, even if you do, because clinics can differ, it's really critical to have a place that can be double checked. And to make sure that the people who are teaching agree, because one thing that really raises anxiety is when there's two different sets of information and people aren't sure what to do. In emergency medicine and other situations where people will forget things over time and have critical procedures they need to do, one classic example is intubation. in an adult emergency room, you might intubate twice a day. Intubate means to put a tube down for breathing, but you may not do this in practice in a pediatric emergency room, but once every 6 months. So there's something called just-in-time teaching, which has been found to dramatically improve successive procedures. And that is just like this little piece at the bottom here. It's a quick review. It's a little review that's got pictures and got some very simple instructions so that each time you could have the quick review before. So adding just-in-time teaching to your starter kit is very important. And then here's the difference between routines and rituals. So routines are doing the same thing the same way each time. One thing that's helpful about that is having a starter kit that has all the stuff together that you're going to need. So your Band-Aid, your alcohol swab, something to remind you how to do things that you need. You can see there's some little just-in-time teaching about Buzzy up at the top of this one, where we show right here where the ice packs and how they go in. That provides a routine that decreases anxiety and increases the chance that the medicines will be given correctly. Now, if somebody does have needle fear, we actually have separate materials for that, sometimes it takes 3 or more times that are good experiences before you start dismantling that and decreasing the pain and the fear by half. It takes a while. But so part of this is the routine, and there are ways to address needle fear in this, but having a routine itself is one of those things that helps. Now, the other part is ritual, and this is so fascinating because people who give themselves painful injections once a week, twice a week, once every 2 weeks, to a person, they have a set of comfort experiences that make them feel better. So I'm actually going to scooch here. Nah, I'll talk about that in a second. So the comfort aspects of a ritual are things like lighting a candle, having music you like, having your older brother have to be quiet, being in one place on the couch, being ready to get a treat afterwards. So that kind of thing is also something that needs to be incorporated so that the events are special and have some positivity that balances having to stick yourself with something. One thing about the routine elements on this page is it's talking about pain relief after. This is Coyne et al. This is just wrong. We would not do pain relief after. You got to address the physiology part before. So ways you can decrease the pain from a physiology standpoint. What Buzzy's doing is it's stimulating the motion nerve that you feel when you rub your elbow. It also adds cold. And so cold is using a part of the brain that is the coordinator, the conductor. So it takes a pain experience and then sends it to memory, sends it to fear if needed, sends it to options, sends it to identity, and coordinates all that. It can also take ice, the feeling of cold, and say, okay, time out. This is not dangerous, but not pleasant. So we're just going to push down all those sensations. So ice plus vibration together is very effective for the physiologic symptom of pain. Now, there's lots of other options. There's topical anesthetics that take about 60 minutes to work, called EMLA. There's a eutectic mixture of local anesthetic, that's EMLA. There's liposomal lidocaine. Interestingly, this is not FDA cleared for needles. People use it, but it doesn't have FDA clearance. Just plain ice is also very effective. And then there's options for distraction. We'll talk about that. But the thing here that's very interesting is if you look at the column that says RCTs for injections, very few papers actually look at pain management options for injections. Almost everybody is looking at IV access and then extrapolating from that. So there are more studies about Buzzy and injection pain than any other intervention, but just be aware when you start thinking about doing topical anesthetics that there's really not much in the way of published literature about injections. And then, of course, there's the cost concern. And so these are some options more from an emergency department standpoint. And this is using a healthcare unit. All right, so in talking about distraction, so to reduce fear and pain, yes, there's a physiology of vibration and cold, but for people who are still afraid, it helps to add something else to focus on. The spotlight of attention can either focus on something that hurts and make you afraid, or you can focus on something else and not even pay attention. If you're playing a game and running around, you don't notice when you twist your ankle until you're at home at night, not playing, and then you start getting worried. So if you are knocked to the ground, you feel completely different if you're in an end zone holding a football versus if you're in a dark alley and a stranger knocks you down. So how you're perceiving and paying attention to the pain makes a big difference. What we found is that the area of the brain that is responsible for pushing that ice signal down also is sorting whether or not, it just does sorting tasks. So you can jam the signal by making it sort something. And so we use distraction cards where you have to do two tasks at once. You've got to count something and sort it. So how many monkeys are doing this? And then you count them. A really quick way to do distraction, if you're an adult or you don't have this, is just to have a sentence to look at and then count how many of the letters have holes. So you're sorting letters and counting. So a sort plus count task is a really good one. And multiple studies show it decreases pain by half. All right, so this is how you would incorporate something like that, putting distraction cards in as part of your rituals. So it could also be focusing on a smell, having lavender, having packets to open, having a glass of wine and smelling that, and then having the ritual be that you drink it right before you give the injection. But rituals are a critical part, and letting someone play with making the things that they want to do that are special just for this, that's what a ritual is. Very personal, and it's for control and comfort. A sticker chart would be part of a ritual. A saving up to get an ice cream would be part of a ritual. Not for the kids, but having a glass of wine, part of the ritual. So having something like this is when you get to play one particular game on an iPad. That's a great example of a ritual. So our goal is to optimize the transition from being complicated to being more simple, and to keep in mind what the goal is and to have the very first experience be positive. One of the things about pain is that it's not just the physiology, what you feel, it's also what you learn. And so your very first experience with something that's painful is going to be laid down as the template that gets Xeroxed each time. So in order to make it as good as possible, you want to make sure that very first experience is optimal. Make it great, make it comforting, and make it reassuring. So Buzzy's got the vibration, you put it between the brain and the pain, you add ice to it. And we talked about that's adding to the inhibitory control. And using rituals and using pain management reduces fear and increases control. All right, here are some examples of people who have been so delighted they have sent us pictures for all sorts of things, from infusions to injections. The ways that different pharmaceutical companies have been involved is almost as varied as the number of pharmaceutical companies. So in one situation, there was a little girl who was diagnosed with Gaucher's disease as a small child. She ended up working with the pharmaceutical company to provide these for other kids once she became 13 and she was doing her bat mitzvah.
I'm a bug weaver. My ladybug makes my sock feel better.
That's also important. Better is what we want to strive for. We don't want to ever tell someone it's going to be pain-free. That isn't helpful and it's not realistic. So better is a great goal. These are just lots of different clinical trials, over 100 of them for biologics, for enhancing adherence, reducing fear. And I'm just going to show you an overview of our partnerships, then some specifics, and then I will open it up for questions in 2 minutes. So Buzzy's been included in starter kits. It has been given to physicians for them to use as training materials. It's been offered through patient support portals, so patients who need it can specifically request it, just like you would a Sharps container. Other places, particularly in the UK and internationally, donations have been made to foundations or patient support groups for them to provide Buzzy to the patients who need it. So, for example, this child, as we just discussed, raised money with and to give the devices to other people who had Gaucher's disease. One group in the United Kingdom, I got this just today, so still the rheumatology nurses are giving away Buzzies to patients with the Scotland National Arthritis Convention. So patients in Scotland can get Buzzies for patients who are, or patients in Scotland can get Buzzies when they need it or are diagnosed. This is the concept of having an announcement to patients who are already on medicines so that they can use this. It helps if you really get started and put it with a starter kit. Once you've gone down, it's hard. For different diseases, different places have used different starter kits. So one really cool thing with a patient who is diagnosed with type 1 diabetes, they were using Buzzy for every finger stick, every injection. And then over the course of about 4 to 6 weeks, they got the medicine really doesn't hurt and the needle is very small. And so they got comfortable enough that they could do the injection without it. So Buzzy is not so much a crutch or something they're always going to need as it is a bridge, as it is a way for the non-painful injections for someone to get over the fear that allows them to do it. Talked about Grifols. In Australia, Pfizer gave branded units to patients with hemophilia. Quest Diagnostics has used this for their injections, and that kind of thing is an option. So hopefully this will give some context and then how to make home injections better, address pain, fear, and focus. And I'm ready for questions. Does anybody have any questions they would like to either put in the question and answer area or in the chat? I know we're going to get questions later. For now, this webinar will be available in about a week, and anyone who signed up will be able to use it. If you are not, and actually it'd be really great if the participants could just go ahead and either put in the chat or the question area. If you guys could just say whether you're with a pharma company, whether you're with, whether you're a patient or a parent of a patient, or whether you are a clinician. That would be really helpful just for me to know what, as I tweak these slides to make them the best for, yeah. So the question is, can these be used for potassium chloride injections? Buzzy is not a combination device. So what that means is that it doesn't matter what injection it is, because you're not giving the injection through Buzzy. You're just putting Buzzy directly on the site for 30 to 60 seconds and then sliding it up and then doing the injection just distal to it. So it's not, and there's a whole other webinar on Buzzy best practices, but it doesn't, yes, potassium chloride, peg asparaginase, it really doesn't matter. It can be used for any kind of injection. It can be used for bee sting. I mean, we're dealing with the pain. It doesn't matter what drug it is. Regards from Cyprus. Hello. Love my child life specialists. Thank you all. All right. Well, I appreciate you coming. Thanks so much. And we'll be sure to let you know the next time we have a webinar from Pain Care Labs.